Nice. All right, we're going to go ahead and get started. Thank you so much for all of you for joining us to hear more about the CMS Innovation Center. My name is Dora Hughes. I'm the Chief Medical Officer and our lead on health equity. We're going to start with just a few slides, and then we're going to move into a rapid round robin, possibly speed dating, where you're going to hear examples from each. And when I was thinking also about how do we introduce this group, this is a very large panel. We had to still beg and borrow chairs from other sessions, and I told them, I was like, I'm going to introduce you as the sensational seven, which was intriguing to all. If you do follow Marvel as superheroes, I do think that that is a very appropriate description for the group here and that the work that they are leading. Please do go ahead and come in and take a few chairs. We're going to move to the first slide. I did want to introduce the CMS Innovation Center. I know many of you may not be that familiar with the work that we do. Just starting while the slides are coming up, we were created as part of the Affordable Care Act in 2010. Our statutory charge is to support models. We call models what others might call research projects, demonstrations, to support models that will either improve the quality of care or reduce the cost of care. And of course, ideally, our models would do both, but at least one of those two statutory charges have to be met. As we finished our first 10-year anniversary, and it was also the change in administration, it made sense to take a look back and think about what did we learn in our first 10 years that can inform our next 10 years. And so with that, if we move to the first slide, we released our new vision statement and strategic objectives about a year ago. Let's see if we can have the slides advance. There we are. And as you see here, our vision statement for 2020 to 2030 is a health system that achieves equitable outcomes through high quality, affordable, and person-centered care. And we have also listed 5 strategic objectives that we hope will allow us to achieve this vision. The first is that we hope to drive accountable care. By that, we mean that we want 100% of Medicare beneficiaries and the vast majority of Medicaid beneficiaries to be in relationships that are defined by accountability for quality and total cost of care. Our second prong focuses on advancing health equity, and I'm going to say a few words about that in the next slide. Our third strategic objective is to support innovation. We want our model participants to be successful in our models, and so we ask ourselves, what is the data that's needed? What are the technology? What is the tools? What are some of the learning systems that will allow our participants to sustainably participate in our models and again be successful? The fourth strategic objective is addressing affordability. And we've really looked at that on 2 levels. At the systems level, how do we drive down costs? How do we eliminate waste and inefficiencies in the system? But we are also looking at the beneficiary level. How do we reduce out-of-pocket? How do we reduce cost sharing for our individuals in the Medicare and Medicaid program? And the final area is just very critical, is focusing on partnership. And I would say in our first 10 years, we were so fortunate to have an amazing cadre, an amazing network of providers, health systems, hospitals, health centers, the range of health-focused organizations. But we're really trying to expand upon, build out this network to include more safety net institutions, safety net providers, those groups representing underserved populations, really looking at across state and local areas. And so partnership is another area that you will increasingly hear us speak more about in the days ahead. So then if we move to the next slide, we're going to talk a little bit more about advancing health equity. I would say as a shameless plug, we released a blog in Health Affairs on May 11th. Feel free to come down front if you need to. We released a blog on May 11th in Health Affairs that provided more details about our health equity strategy and, more importantly, the progress that we were able to make over our first year. But when we talk about our health equity initiative, we have 4 areas of focus. The first area, as we develop new models, how do we better embed equity? The questions that we're asking ourselves are, who's on the care team? Are we able to bring in community health workers or other community-based partners? What's the financing structure? In some cases, people say you could start with that one first, but we know that if for our providers taking care of more medically and socially complex patient populations, they need more resources. And how can we test different ways of providing these resources? What's the level of funding? What's the structure of funding? Should it be upfront or spread out? Those are questions that are part of our model tests. We also thinking about the care delivery requirements. What changes could be helpful there in the context, again, of equity? If we move to the second bucket, that is really thinking about how can we diversify the beneficiary base that's served through our models. In our first 10 years, in our look back, we realized that some of our models were not particularly diverse in terms of the beneficiaries served or the types of providers that were participating. And so as part of that, key to the strategy is we are looking to embed more safety net providers in our models. How can we work more closely with HRSA, for example, bring in more community health centers or rural health centers or more Medicaid providers? That is part of our second strategic objective. The third area, evaluation. We want to know at the end of the model lifetime, what has been the impact on health equity? And the fourth area we think is just absolutely the linchpin across all of these different areas. How can we strengthen the data collection and reporting for all underserved populations? Here at CMS, we're fortunate, certainly we have some data for racial and ethnic groups. It's limited in many cases, but we do have some of that data. But where we're even more limited is we think about other populations, people with disabilities. In some cases, we know if they're disabled, yes, no, but we don't know the nature of the disability. We don't know the types, the severity. So how do you design interventions that can improve the quality of care for such populations, for these beneficiaries, without that type of granular information? Similarly, we're also especially more limited in data for populations defined by sexual orientation and gender identity. So across these four areas, embedding equity through our models, increasing more safety net providers as a way to diversify the beneficiary base, evaluation, data collection, those are the four areas of focus. And I'm so excited. Through our 7 different groups, you're going to hear examples and highlights of how we are living out this strategy. And certainly, if you want to learn more, I did want to put our website, our contact information there, and other resources if for those that want to take a picture with the phone for additional references. But they're also online for those that want to link to the agenda. So with that, I'm going to go and have a seat, or not. I'm going to go stand. I'm going to go and move to the corner, and I'm going to ask Sarah Fogler to start. I would love for you to say a little bit about your group and then provide some highlights. Thank you very much.
Hi folks, Sarah Fogler, and I'm representing the Patient Care Models Group in the Innovation Center this afternoon. So thanks to all of you who have joined. My group in the Innovation Center has the charge and privilege of leading the design, development, and implementation of the primary care portfolio at the Innovation Center and also the specialty care portfolio. So we have a very broad and deep reach. And since our audience maybe quadrupled in the time that Dora was speaking, I just wanted to remind folks that our role for CMS is to test new innovative ways for delivering care and paying for care for Medicare and Medicaid beneficiaries, with the ultimate goal of scaling some of the successes into the traditional Medicare and Medicaid programs. So Dora has asked for us each to give a little flavor of how we've tactically started to implement some of the 4 prongs of the strategy that she walked through a bit earlier. And so I'm going to tackle 2 of the particular models that sit within the Patient Care Models Group at the Innovation Center. And as I said, we focus on the primary care portfolio and also the specialty care portfolio. We have 1 active model right now referred to as the Enhancing Oncology model, and this is a model that's built on a bundled payment framework, and it focuses on episodes of care for patients who are hospitalized either with a medical illness or need for cancer treatment. These are opportunities, both this and the primary care model I'll get into in a moment, to reduce disparities and improve equity in all areas of care, which, as you just heard, is a central focus for the Innovation Center, not just the group and the models that I work on. The Enhancing Oncology Model, or EOM as we refer to in short, seeks to improve the quality of care and achieve equitable health outcomes for all Medicare and Medicaid beneficiaries. In alignment with CMS's commitment to reducing health disparities and achieving health equity in CMS quality programs, and within the Innovation Center model specifically, EOM is designed to advance health equity within all stages of model implementation and evaluation. There are a number of things that will resonate with the items that Dora walked through in terms of our strategic objectives, in this space. The first is EOM participants, so that's providers, will be required to collect beneficiary level sociodemographic data. For example, race, ethnicity, language preference, disability status, sexual orientation, gender identity information. We'll collect that from all beneficiaries receiving services through the Enhancing Oncology Model and ask providers to report that data to CMS. This data will be used for CMS's monitoring and evaluation activities and may also be used to inform feedback reports that we send back to our EOM participants, who again are the providers, and feed our model dashboards so that our provider community has a better understanding of the patients they serve in full. We're also incentivizing care for the underserved in our Enhancing Oncology Model. The EOM payment methodology acknowledges and is responsive to the greater resources that may be needed to care for complex and underserved communities. For example, through risk adjusting cost benchmarks and providing additional resources for more resource-intensive care management of complex patients through an increased per beneficiary per month payment for enhanced services. These can include things like navigation to community-based resources, for example. On health-related social needs, we're also asking EOM participants to report to us use health-related social needs screening tools and also collect and report that data to CMS as well. We believe that social needs may be addressed through patient navigation, care planning activities, and other partnerships that are established between the providers and the communities in which they serve. At this time, we're not requiring necessarily the reporting of sociodemographic information, giving a small grace period to providers participating as they get processes in place, but we do expect, as Dora mentioned, to move towards this in the future. We're also expanding access in EOM to participants by asking them to provide 24-hour access to clinician services with real-time access to the patient's medical record. If any of you follow many of our primary care models, this concept is featured in those models as well, improving access and medical record review. We're also, and you'll likely hear this from my colleagues, requiring health equity plans to be established by providers that are participating in our model. This is part of the need and request for data that we'd be collecting for continuous quality improvements efforts. We believe it's important for EOM participants to identify and monitor for disparities when they exist in their patient population. So improving awareness and working on an annual basis with providers to improve upon their existing health equity plans. We found our oncology community to be very enthusiastic to work collaboratively with us to address disparities of care, and we're going to continue to work through this process as we move through years of implementation with that group. I'm going to close with just a couple bullets on our primary care first model, which is different from our specialty focused oncology care model. It's a model for sophisticated primary care practices to implement advanced primary care services. So improving on access, improving care management and coordination, improving relationships with communities to meet health-related social needs for their practices, and paying differently for services, not based on value, but based on volume. I wanted to highlight this model because the important work they've been doing as one of the first movers at CMMI for our health equity data reporting initiative. 238 of our participating practices volunteered to enroll from our 10 PCF regions in reporting the demographic data to CMMI as a pilot. This, as we mentioned, will likely become the standard for CMMI data reporting in the future. 223 practices from 10 regions ended up submitting data to us. Their reporting was required to be aligned with reporting standards. And the most common reasons practices gave for enrolling in this reporting initiatives was that they believed health equity to be an important aspect of healthcare. When asked what practices plan to do with the data, they responded they plan to use the data to reduce disparities and will review the data with their QI committees regularly. The successes of this data pilot are an important first step for the Innovation Center as we move toward making model participants not just report demographic and health reported social needs data, but work with us to improve health equity and reduce health disparities in the future. Thanks so much. I'm going to introduce Lori McWright, and she is going to represent the next set of models from the Seamless Care Models Group. Thanks so much.
Thank you, Sarah. So maybe the first order of business is if anybody has a seat next to them that they want the people outside to come and take, that would be great. Why don't you raise your hands, because there's seats down here. So great. Yeah. So I'm Lori McWright, and I'm the Deputy Director of the Seamless Care Models Group within the CMS Innovation Center. And as the name describes, our group addresses models in the integrated care delivery settings, and that's really looking at care that's provided really sort of soup to nuts, as opposed to the way Sarah described in terms of focusing on a specific kind of care, specialty, primary care. The Seamless Care Models Group houses models that have ACOs, health plans, specialized ACOs, and that's our sort of, I guess, if you will, piece of the CMS pie. And today, I'd love to talk to you about a couple of our models that are really the poster children in our group for focusing on health equity, promoting it, and really, I think, in line with the CMS framework for addressing health disparities. So the first model I want to talk to you about is the value-based insurance design model, or the VBID model. And that's really the only Medicare Advantage model that's focused on the MA population in the center right now. And I think we think of it as really a unique opportunity to partner with health plans, 52 participating organizations, to test an array of flexibilities that can provide supplemental benefits, interventions that are really looking at improving health outcomes, care delivery, and also trying to lower the cost for over 6 million of our enrollees. And at the moment, I believe, as we say, we have 52 participating organizations, and it's across 49 states, DC, and Puerto Rico. Now, as Sarah talked about, one of the requirements beginning in 2024, so next year, is for all participating organizations to submit a health equity plan. And really, that's the opportunity for plans to tell us about their evidence-based strategies to address health equity issues. And we want them to answer basically 3 important questions. The first question is, how will MAOs monitor for health inequities and also be able to also include measures of progress? In other words, how are they being addressed? The second question that we'd like answers really is what's an MAO's goal related to health equity, and how are they going to make sure that they achieve it? And then the third one, we think this is maybe the most important one, is there a champion within the plan for implementing the health equity plan? And so we're excited. We received the health equity plans through the VBID application process recently, and a lot of interesting proposals in there. Now, one way that VBID promotes health equity that I think is probably important to mention is the targeting of certain benefits and interventions to specific populations that are of particular, I guess you would say, particular need. And need would be described as socioeconomic status, or having a chronic health condition. And the targeting could potentially be, a healthy food card, transportation assistance, a variety of interventions addressing social determinants of health. So a couple of examples of how those of how plans could implement would be perhaps a plan could reduce Part D drug cost sharing to $0 for an enrollee who has, say, $7,000 or less in resources, financial resources. Or another possibility might be that a plan would target healthy food cards or rental assistance to enrollees with a chronic health condition such as diabetes. So all kinds of possibilities there. I guess it's really just safe to say that the VBID model has health equity instilled in really all aspects of its design. And I could go on a lot more, but I want to get to the second model, which is the Accountable Care Organization REACH, or Realizing Equity, Access, and Community Health model. And that is a model that we're very excited about and has really been designed in order to address health equity issues in its current version. And it's really about providing providers the tools to be able to address health equity issues in terms of the way they're structured, their team-based approach, the really person-centered care, I think overall would be the best way to frame it. And I think there are 5 overall provisions within the ACO REACH structure that I'd want to point to that are important. The first being, not surprisingly, a health equity plan. And that's really designed to make sure that the REACH ACOs are able to identify the underserved population within their midst, and to be able to identify measurable ways to address the health equity issues. And they have to, like with Sarah, the reporting, hugely important. They have to report annually on their progress of achieving their goals. And the plans that we've seen initially are quite promising. I mean, we've seen a number of initiatives that are designed to address medical conditions such as diabetes, hypertension, as well as all the health-related social needs such as health literacy, food insecurity, and transportation, a really important one. The second provision that's definitely an important one to mention is a health equity payment adjustment. Now, as some of you may know, in the past, our ACO initiatives have addressed medical issues, but have actually not hit the patient population that we wanted to, which was the underserved population. I believe that it was more targeted to the general Medicare population. So to address this dynamic, we have inputted a patient level adjustment for ACOs, and it's the first of its kind, and it's really designed to increase the payment benchmark for REACH ACOs that are treating higher proportions of underserved patients. And the adjustment is based off of an area deprivation index, a composite measure of underservice that takes into account the Medicaid status as well. And that'll be implemented this year. And so far what we're seeing is very exciting, where we've seen, I believe, about an additional $3 million being provided across the ACO REACH patient population. And we also have the fourth provision would be the reporting requirement, and that's just to make sure that we're getting in data that's meaningful on health equity measures and demographic data, to start out with race, gender identity, sexual orientation, information on all the social determinants of health. Very important. We have an incentive that's attached where ACO REACH entities are able to have a higher quality score attached to payment if they are submitting their data timely, et cetera. And so we're done. Yeah, so there's a lot of things to say. So, okay, so the bottom line would be that these two models we're really excited about, as you can tell, and we'll look forward to how they grow and develop and where CMS can do additional interventions and supports on health equity. Okay, all right.
All right, so I don't want to get the hook, so I'm going to try to be as concise as possible. First of all, my name's Tequila Terry, and I'm the director of the State and Population Health Group at the Innovation Center, and I'm so delighted to be here because I'm so excited about the work that we do. A little bit about our group. We have a really diverse set of models that we run in our group, where we work in one part of our portfolio is directly with state governments, to use the policy levers that they have to address cost and quality. We also work directly with providers on key areas of addressing how care is delivered for conditions like diabetes, cardiovascular disease, maternal health, rural health, behavioral health. And then we have a part of our work that's really focused on looking at the role of community and how we can use community strengths to address the upstream factors of health, which we all know play a part in outcomes. And so that's the part that I want to focus on today. And I want to give a shout out to my colleagues in the audience, Sarah Downer and Kate Johnson, who have been really integral to this part of our portfolio. Some of you may have heard, by show of hands, how many of you have heard of the accountable health communities? There we go. Look at that. It's a beautiful thing. So I'm going to talk a little bit about that model because it really was on the forefront of the work that we do to address those upstream factors of health. And so there are a number of things that we're learning from that model that we're starting to integrate, as you heard, into many other areas of our work. This year marks the winding down of the accountable health communities model. I know you all are looking sadly at, go ahead. Oh, yeah, there we go. And our learnings from this model have been so significant and so important as we think about health equity and where we as a center and a part of CMS go next. So I want to take just a couple of minutes, and again, don't pull out the hook, but a couple of minutes to talk about sort of four key areas. Many of you raised your hand. Many of you are familiar with the accountable health communities model, but to set the stage, essentially what this model is designed to do is to address the critical gap that exists between people who need help from the clinical care system and then those resources that we know are really very important in the community. And we wanted to, through this model, test whether systematically identifying health-related social needs through screening, through referral, and in some cases through navigation, would actually help us to address healthcare costs and reduce healthcare utilization. So that's what we were testing. There were sort of these two tracks in the model, the assistance track that was really designed to provide community service navigation to really high-risk beneficiaries. So those are people with at least one health-related social need and 2 or more ED visits in the previous 12 months that they were seeing. And the goal was to help them access those community services to address those health-related social needs. The other track was an alignment track. So it's this recognition that partnership was really critical. And so to encourage partner alignment, this track was designed to ensure that community services were available and responsive to the needs of beneficiaries. And so that's, in a nutshell, what the model is about. There are 4 key things I want to leave you with as highlights of what we have learned from this model. First, the accountable health communities model demonstrated that screening, referral, and navigation are not only feasible, They're not only appropriate, but they're scalable. This model was actually implemented in 328 counties across 20 states, including 7 of the 10 largest US cities, in rural areas, in suburban areas, in urban areas. So it can work. So if you're thinking about doing this, it can work, it can happen. Second, the accountable health communities demonstrated that there's a tremendous need to support people who are grappling with health-related social needs. We screened approximately 1.8 million people in this program, and nearly 40% had at least one health-related social need. So that means they were grappling with transportation, food, housing, paying for utilities. And so thinking about the scale of, the impact, the prevalence that exists, that's another takeaway that we wanted to share. Third, we wanted to really underscore that people want help navigating. Of the people that were eligible to get navigation services, 77% said, yes, we want that help. We want assistance. And we only expected that to be about 30%. So clearly there's a need. And then fourth and finally, impact was made through this model. Claims data collected demonstrates that there were some statistically significant impacts on utilization as a result of the model. Specifically, there were fewer ED visits. There was a drop in avoidable ED visits, so very quantifiable impact. And so in closing, I'll just say, again, as we think about what we have learned from the accountable health communities model, we have a good strategy for identifying unmet needs among our program members. So if you're thinking about doing this, there's a ton of resources we have available that you can use. The needs are prevalent. People need this kind of support and these services. And many of the program members want the help. So having services available will be utilized. And then finally, we will really see impacts on utilization if you implement these types of procedures of screening and referral and navigation. And so I would just leave you with that, an opportunity that exists across the country. The lessons learned that we have gathered through this model are ones that not only we hope you all can implement, but they will be used to inform our thinking as we move forward. So with that being said, I'll say thank you. Hopefully I stayed under the wire, and I'll turn it to Susannah.
Hi, good afternoon. I'm Susannah Bernheim. I'm really happy to have a chance to introduce myself and talk a little bit about our work at the center. And I'll note, you heard from Sarah, Lori, and Tequila about specific models. I'm now the first of the speakers who are going to talk about some of our cross-cutting activities and work that we do across the groups. I am a family physician and health services researcher and recently joined the Innovation Center as their Chief Quality Officer and Senior Advisor. So my team develops and implements our advancing quality strategy. What I mean by that is that we support the models as they are building their quality strategy, providing teams guidance on what measures to use and how to use them to advance care quality. We also do some cross-cutting strategy both within the center and with our colleagues at CCSQ and other parts of CMS, and whenever possible with other payers. So today's focus is really about health equity, so I'm going to spend just a couple minutes talking about how we think about the quality strategy in general, and then focus on some of our equity specific measurement activities. So when we are building models, we aim to think about quality measures that are really closely tied to the changes in care that we hope we'll see. These measures hopefully can therefore be a North Star for the providers participating, incentivize improvements in key areas, and guard against detriments in the quality of care. We also use them in evaluation, and Noemi will talk about that, to help us understand what the model has achieved. But we also think about measurement burden, and we think about alignment, and some of you may have recently seen work across CMS to more closely align our measures through the Universal Foundation. And at the Innovation Center, somewhat in tension with that, we're really committed to the use of novel measures and patient-reported outcome measures. And so we have to think carefully about how to balance these two things, about measurement burden as well as testing novel measures. And I think one of the things that drew me to the Innovation Center most of all is a partnership among all the groups on this panel, which is a real commitment and interest in using measurement to better understand the impact of our models and to really focus on quality and outcomes. So I'll shift to talking specifically about health equity and the ways in which quality measurement can help us advance health equity. First, what you've really heard today across the board is that in the last couple of years, the center has been keenly focused on embedding health equity throughout the design of our models. And that in particular relates to attending to what people, what patients, what providers are a part of our models and the data that we collect. And this work is really fundamental when it comes to our capacity to use quality measurement to advance health equity. It depends on us working to transform care among providers who can have the biggest impact based on the patients they serve, and for us to understand the demographics and lived experience of those beneficiaries, asking about race and ethnicity, disabilities, health-related social needs. In some cases, we therefore measure directly these data collection activities as part of our quality strategy, but more importantly, these strategies change our capacity to use measurement to advance equity. So it's really a cascade of measurement activities. First, building measures and capacity. Next is using that data to better understand differences and disparities, both among providers and between patient groups. This is really all about the stratification of quality measures. And in the center, we are primarily doing this through providing information back to providers. You've heard about some of that, and encouraging and supporting providers to look at stratified information, partly through things like their health equity plans. So we are going to continue to evolve our efforts related to measure stratification as we learn from these activities, and also in collaboration with other parts of CMS who are doing similar things. I want to talk about the importance of the patient voice in our measurement efforts. As part of the Innovation Center's strategic objectives to support innovation, we've set very specific goals about the use of patient-reported outcome measures in our models. Patient-reported outcome measures ensure that we hear directly from people served by the providers that are participating in our models about their outcomes and experience. And to do this well requires, as we continue to learn, careful attention to implementation challenges. We need to make sure that we don't overburden the patients and people who we're serving, and that the information that they report gets in the hands of clinicians in ways that it can be used for decision-making. So we really have to think carefully about how to do this work. But hearing directly from patients about their experiences and outcomes can really illuminate some of the barriers to equity in unique ways, and therefore it's really important. It can help us by hearing about the experience of respectful treatment and care decisions, or hearing about accessibility for patients with disabilities or those with language interpretation needs. So we're working to thoughtfully incorporate PROMs throughout our measurement activities going forward. And the last thing I'll say, and you heard this from Tequila and others, and part of why I'm here, is that we're really committed to learning through the implementation of these models. So as we test new strategies to use measurement or put novel measures into place, our strategy will continue to evolve. We're poised at the center to really learn through our evaluation and continue to evolve those measurement strategies. Thank you.
Hello, I'm Kate Davidson. I'm the director of the Learning and Diffusion group at the CMS Innovation Center. So the problem with technology is that people can access you at any point in time, and Nora told me that I have to cut my talking points. So we're gonna get this going. And really fast. So listen, so the Learning and Diffusion group, you've heard a lot from all of these ladies about the tremendous work that's happening at the Innovation Center. And the Learning and Diffusion group, at the heart of what we do, at the heart of our work, is really ensuring that model participants can be successful in our models, and also recognizing that our models, our payment models, and our flexibilities that we have through our policy waivers, benefit enhancements, et cetera, really are just enablers to support transformation at the point of care delivery. And so the Learning and Diffusion group has the opportunity to look inside to understand what our model participants, whether that be a large health system, whether that be a smaller primary care practice, whether that be a specialty care, what they are doing to change care and to affect patients' lives, which is ultimately what we're all trying to do here, is to improve outcomes. So in that capacity, the Learning and Diffusion group has a really interesting and I think unique vantage point. Number one, we have the opportunity to look across the portfolio to see where there are similarities in models, where there are differences in models, but we also have the opportunity to look across the life cycle of that portfolio. So when I say that, I'm talking about the life cycle of our models, and that means design, which Sarah talked a little bit about, implementation, which really design, application, which is important, and I'll come back to this, implementation, and then also scaling or evaluation as well. And so a couple of years ago now, and I would just say, my team is responsible for asking a lot of questions. We're like one of those, we kind of annoy the model groups because we're like, what does this actually mean on the ground, right? And so that's kind of our role at the center level. And so you'll hear that in these examples. A couple of years ago, we set out to answer this question of what beneficiaries and what communities are our models reaching. And which ones aren't they? And what we found through that analysis, this footprint analysis of our portfolio, is that predominantly and in many spaces, our models were really focusing on and touching communities with high socioeconomic status. And so that helped us to think through, how does this impact our model design work? And I'll talk a little bit about that in just a second. But it also led us to ask questions about what that meant for application, like, are we actually turning folks away that are serving underserved populations? And so we did an analysis on our applications we partnered very closely with our primary care teams to understand through their application process if we had implicit bias built into it. And turns out we did. We found out that we had a lot to learn about who we were accepting into our models, how we were designing our applications, and how we were conducting that process as well. And so that led us to where we are today, which is, as we're designing new models, we're really taking all of that information and building that into our letters of interest, into our requests for applications, as well as building the infrastructure to do real-time analysis about who's coming in and who's applying to our models. So what does that mean for recruitment? That means if we're able to see that we are missing certain communities where we had intentionally designed models to be able to target, we can pivot and we can do recruitment activities, reaching out to those communities, reaching out to those providers, in order to really try to ensure that the intended audiences, the intended beneficiaries, are engaged in our models. I'm going to move on to the implementation phase a little bit. You heard a lot of themes from Tequila, from Lori, from Sarah, about some of what we learned both from AHC, I think, that we've been able to bring forward, and then also the new models that we're designing that all include the health equity plans. So what do we do with that information once we get it? So in the learning systems, when we gather information from the health equity plans, when we are looking at how folks are screening for health-related social needs, which we've scaled into our models, we use that information to send it back out to the model participants and help them make those connections that Tequila was talking about with community-based organizations, for example. So it's not enough just to screen for health-related social needs, but then how do you actually connect those patients with services? And the learning system designs content that helps folks to make those connections. I think one of the really interesting things that's happened as we've really been focusing on health equity is the relationships that we've developed at the federal level as well, in order to maintain some of those connections. And so Dora talked a little bit about the relationships we've been forging with HRSA, but I think I also would call out our partners at ACL, who have really been instrumental in helping us think through how we can build bridges with community-based organizations. I'm going to not talk about evaluation. I'm going to let Noemi talk about evaluation in just a minute, and as well as scaling. But you can see here through kind of like the picture that I'm painting about how the lessons that we learned from previous models some of that work gets built into existing models, and that cycle continues across the life cycle. The last thing I'll talk about is that what the Learning and Diffusion group is responsible for is we oversee the Healthcare Payment Learning and Action Network, or the LAN, which is the biggest private-public partnership that CMS run or contributes to. And a couple of years ago, we launched the Health Equity Advisory Team, or the HEAT. We brought together a number of experts as well as implementers from the field to help us think about what are the key design features in APMs that need to be intentionally built into our payment models in order to be able to advance equity and reduce health disparities. So those resources are available on hcpland.org. I think that's what, yeah, hyphen in there. But in addition to that, we also released a paper last year on social risk adjustment, which was contributed through a number of experts and implementers, as I said. And then finally this year, we're really taking on some of the work that folks have been doing in the field already around making those connections between payment models and providers, and in really trying to right-size that power dynamic between health systems and community-based organizations. And so that's a really, I think, important set of work that's happening. At the same time, that feeds into some of the larger work that the LAN does around the executive forum and some of the national payers, as well as the regional payers and providers, as they're going to implement some of this work around equity as well. So with that, I will pause. I hope I was fast. And I'm going to hand it over to my colleague, Noemi.
Hi, good afternoon. I'm Noemi Rudolph. I'm the director of the Research and Rapid Cycle Evaluation Group. I was just named the permanent director at the end of March, so relatively new, but I have been at CMS for a good long time. My team is responsible for generating the information and the evidence about our CMMI models that we test to inform the policy and decision-making at CMS. So we do this in several ways. We actively participate with our program team counterparts in designing the model. We conduct the rigorous evaluations, which I'll talk a little bit more about, of the CMS models. We also do some policy relevant research beyond just the evaluations. And finally, our work is very technical. And so we have been spending a lot of time in figuring out how to communicate and disseminate our results in a way that can be, that's actionable and that our non-research community can understand all of the intricacies of our models. Why are evaluations important at CMMI? Every CMMI model that we test is required by law to be evaluated. And so the evaluations are used to make decisions about expansion, about termination or modification of our models, as well as informing any future model design. But in order for us to expand the model, which one of our goals about is to expand the model nationwide after we do the tests, is but in order to do that, though, the chief actuary needs the evidence in order to do the certification. And then in order to make this certification, however, around whether our models reduce costs or improve quality, the actuaries need a high degree of certainty that the results that we're detecting can be attributed to the model. And so, and those are really, that kind of evidence can only be achieved with impact estimates from the evaluation. And so in our world, data is key. And also sample size is key, and being able to generate a comparison group for our in order to have a counterfactual to the things that we're seeing in the participants and the beneficiaries who are in our model. And so so in order to do this, and in order to look at equity in our models, we work very closely with our program team counterparts here, and actually we collaborate with across the board with this whole panel. We ingest a lot of the data that comes out of the models. But before that, though, we really do work with our model team to help them define their health equity goals, the specific hypotheses that they would like to test with the model, determine the measures, and so that we can, and also the data to track the reductions in health disparities and how they would like to expand health equity. You've heard a lot about health equity plans that we are gearing ourselves up for, and so we have been working with our across the center in determining some of the standardized components and helping them to devise some of the clear scoring criteria of these health equity plans. And also collaborating with our in work groups across the center and at CMS to improve upon and augment the quality of the health equity related data. We do need data that's at the individual level and not just the aggregate in order to be able to conduct our rigorous analysis and attribute the effects of the models to the effects into, I'm sorry, tripping over my words, in order to be able to attribute the effects that we're seeing in our evaluations to the models. Our evaluation contracts are designed and are very theoretically grounded. And we use essentially what we call a mixed methods approach. We use both qualitative data and quantitative data in order to run our evaluation. And we ask that our evaluation contractors integrate health equity through all aspects of the evaluation. And so going forward, how will we use a lot of the health equity related data, such as the health equity plans? We will continue to collaborate with our program teams and marrying it up with marry the health equity plan data with our evaluation data, and to see how we can achieve our goals and how to effectively close the health equity gaps. And one of our goals is to take, for example, the health equity plans and design systematic surveys to track over time and integrate the health equity plan assessment needs into things like our evaluation interview site visits and protocols to assess the impact of these health equity plans on the implementation of the models. Other measures like the health-related social needs measures, where we will continue to work with our social determinants of health measures team to develop a streamlined and consistent high-quality data collection of these measures. And we'd like to move it to just not just only collecting the health-related social needs, but also being able to track the referrals and the resolutions after the identification of these health-related social needs. One of the things that we're thinking going forward is to conduct the site visits, geographical scans, as well as structured assessments of the care and delivery programs and processes to identify the gaps in the data collection procedures on closed-loop referral systems and health-related social needs. Collecting these referral and resolution data will establish the benchmarks and guide the development of our future health equity models. We're excited about the CMS core sets data rolling out, and we think this will allow us to better describe and understand our model populations, but also to conduct cross-model analysis. So we do individual model evaluations, but one of the things that we do try to strive for is to also look across our model portfolios or sets of our models within a given space, like primary care or specialized care, and be able to distill some lessons learned from them and use them to inform design of future models. And finally, again, my world is all about data, and so anything we can do in capturing consistent and high-quality individual race and ethnicity data helps us in conducting our analyses and be able to say about our subpopulations. In the work that we've done in the evaluation group, a lot of the impacts that we've been able to say has been limited at the model level, and we really would like to move beyond that and to be able to speak about the different subpopulations within our models so that we can learn more about how to better target and be able to say more about the impacts of our models on these subpopulation groups. So I will stop there and turn it over to Nora.
Operations is always the last thought, but it is, however, very, very important to enable to make all of the stuff that everybody just talked about happen. So I'm a senior advisor with the Innovation Center. I work with a large team of folks on IT and operationally related contract stuff. And one of the things that we've been really trying to do with the data collection that everybody's talking about is make sure that we're doing it in a standard and interoperable way. So the Office of the National Coordinator, which is a branch under HHS, has set forth standards for data collection. It's called the United States Core Data Interoperability Standards, so USCDI. So in designing our data collection for all of the models, we're trying really hard to use the latest and greatest of the standards. And that is because version 1, which is what all of the EHRs that everybody is using is coded to, did not include even, I think, the SOGI data until the end of 2022. So ONC will put forth standards in a rule, hooray! And then the IT people who have to actually code to them need some lead time to put those together. So recognizing that, IT doesn't happen overnight, we're really trying to say, well, we'll try to use version 3. Like everybody, all of our contractors, everybody, we are interested in getting more data about individuals that's actually representative of the individuals. We also, to the point that Susannah was making, want to do it in a burden-free way. So we're asking docs and clinicians to ask people about race, ethnicity, SOGI, disability, social needs. And when you're a patient sharing that information, obviously you want that information used. It's really not, it's very personal stuff, and it should be available to the clinician. So we want to make sure that the clinician's able to ask it in a way that gets it captured into the health record so that it can be shared, so that when the patient is seeing the podiatrist on one corner and then has to schlep across town to see their endocrinologist or primary care doc, that we want that data to go back and forth. And also we want it to be, to Tequila's point, with the community services that are helping to meet the social needs that we're screening for in the medical setting, but we can't necessarily treat in the medical setting. We want to make sure that there's coordination. And so the way to do that is to be able to actually have like an app that sends your need to the food bank, and then the food bank so that they can send back to the provider to say that yes, your patient has actually been able to come in, and we've been able to get them some of the healthier food that you recommended that they start trying. So those are all sort of big, lofty goals. So the Innovation Center models, we've designed templates in Excel that are mapping to the USCDI standards, and that are also using FHIR, which is Fast Health Interoperable Resources. There was another session right now that was way more detailed about the technical, so I'll assume most of you are not like super in the technical weeds, but it is really, if you've heard about FHIR, it is supposed to be the easy way that I can go knock on someone's EHR, say, hey, here's a couple of questions and I want standard answers back from you, and then I can move them over here so that this other provider can have that information handy, so they're not having to ask the patient the same questions that they just filled out, in 3 other doctor's appointments. So in line with the equity, we're also trying to make sure that we're pulling in FQHCs and other providers that haven't historically participated in our models. And those providers tend not to have really deep IT budgets. So we're trying to make sure that we can use bulk FHIR, we can use APIs, we can use the more sophisticated IT to collect this information, but we also want to make sure that we're not leaving people out and that there are ways to collect, capture, and send the information in for providers who aren't quite as IT sophisticated due to either budget or just general resource constraints. So, so my shameless plug today is for please, 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 interoperability standards are great, especially in the social needs space. There's a Gravity group that's working to define what the questions that we should standardize around on for the social needs determinants settings like housing, social, emotional security. And if we could get those standardized sooner, that would be super great, because if everybody goes off and does their own thing, then you maybe can make some really great progress in your local zip code, but I want to think bigger. I want bigger progress across the country. So to the extent that we have similar data coming in from everybody, then we can assess whether our models are actually really doing something good, which is great. We want to make that bigger. And also we want to know sooner if the models aren't doing something good, because we want to stop and reassess and, pivot. So that's my plug, and I'm probably out of time. Thanks.
Thank you so much. I would also have to say, Nora says operations last, and CMMI operations also manages our budget. So last on the panel, but first in my heart, but we are exactly at time. So thank you again so much. I hope you'll join me one final round of applause for our sensational seven. And we genuinely hope that you'll reach out with any suggestions or recommendations for how we can do better, how we can partner, what else we should be thinking as we move forward in this work. So thank you so much again. All right, we made it down to I was trying to scroll who else's phone number do I have? I do.